All right, there we go. So today I'm going to be talking about some of the nuances of using the web device. I did make some slides on the data underlying the usage, but I believe some of that might be duplicated from prior speakers. So I'll try to go through them fast. Before anything else, these are the approved indications: MCA bifurcation, ICA terminus, ACOM, basilar apex. And obviously wide-neck aneurysms with dome-to-neck ratio more than 1 and less than 2. And this is how the device looks. So it's a braided device that's made into a basket, and it has these markers. So there's a distal marker, there's a little concavity at the distal end, there's a little concavity at the proximal end, and this is the detacher. So this is how it's supposed to sit in the aneurysm. We keep going. The wires are made of this drawn and fill tube technology, so there's a platinum core to it, so it's a little more visible than what we used to have. This is the delivery system. And there are two broad subtypes of the web device. One is the single layer device, and the other is the single layer sphere device. The single layer sphere device is used when you have a tapering neck or a slightly narrower neck or an oblong aneurysm. You can use it there too. And this is one of the most important things you need to have in your institution if you're doing web, these sizing charts. So they tell you, according to your aneurysm width and the minimum aneurysm height, what kind of web device you had to choose. So the previous one was for the SL, and this one is for the SLS. And the web is delivered through the via microcatheter. It's a slightly more robust system than prior microcatheters. There are 3 different diameters. There's the 021, 027, and 033, depending on what web device you're going to use, what size web device you're going to use. And if you go back to these charts, they also tell you which microcatheter you'll need. So the web device has had an evolution from a dual layer device to a single layer, and now the single layer enhanced visualization. What kind of problem does it aim to address? Well, the main problems that it aims to address are incomplete occlusion with endovascular treatment, particularly in wide-neck aneurysms. So multiple studies have been done, and in fact, it's been more extensively studied than many other devices prior to their launch. As far as the USA is concerned, there's the WEB study that was done here. And another important study to keep in mind is the CLARIS study, which is the long-term good clinical practice data on ruptured aneurysms. The WEB study was 150 patients. I'm not going to go into great detail about it. I'll stop where I think there's something to be gained from stopping there. So primary safety endpoint is death from any non-accidental cause, major stroke within the first 30 days, and major ipsilateral stroke from day 31 to 1 year after treatment. When you look at your follow-up images in web, you're going to look at it a little differently, where in terms of coils, we would call these as aneurysm recurrence or inadequate occlusion using our RR scale. Here we have a different scale. Remember, it has a concave recess, so something like this is acceptable, but entrance of contrast around the device is not. So in terms of the percentage of patients for unruptured and ruptured, you can see that most of the patients were between 4 millimeters in size and 8 millimeters in size in both cases. This is an important slide. So the fluoroscopy time with web device is much shorter because you're just implanting a single device, not putting in multiple coils. And The WEB has been successfully delivered in that trial in 98.7% of the patients. So as we keep going, the adequate occlusion rate at 1 year is 84.6%. And if we look at the effectiveness results by aneurysm location, it's very effective for basilar apex, ICA, ECOM, a little less for MCA. MCAs tend to be much more complex than what we even consider them to be on angiography. So there have been no deaths from the device. It says here there's a 6.8% ischemic stroke rate, but really there's just one patient who had a disabling stroke. All right, so I'm going to skip all this and go straight to the device. So WEB deployment, how to do it. The most important aspect of putting in a WEB device is to spend time on sizing the device. So you need to have a good 3D image, and you need to be able to clearly separate and demarcate the neck from the branching vessels. I do not actually do my measurements on the 3D images, even though this slide shows it like that. I choose these for the working projections, and I do my measurements on the two-dimensional images because I believe they're more accurate. Now, some people insist on this being transparent or whatever. I don't care. It can be any 3D volume rendered image. It doesn't need to be transparent, translucent, all these things. They don't make any difference. And when we think of the planning, we have to think about the aneurysm size. Just went through that. You have to think about, is this a regular appearing aneurysm? Does it have a bleb on the side? Does it have a bleb at the neck? We'll go through some of those things. The other important item to consider is the angle at which the aneurysm comes off the bifurcation, because for a couple of reasons. One, to track the more robust VS system, then you have to plan ahead. Two, when you detach the device, again, there are some nuances that you have to follow. For unruptured aneurysms, I believe in always being prepared. WEB or coil or anything, I always prepare my patients for a possible stent. Nowadays, I mostly use ticagrelor. My dosing is 45 BID. Yes, I do PRUs. Yes, I know there's no conclusive evidence. But the standard, obviously, is clopidogrel and aspirin. Now, obviously, the patient is ruptured. We're not doing all this. Post-procedure, generally, I don't keep them on anything. Once in a while, if I feel like there's a very broad interface with the parent vessel, I'll keep them on just aspirin for a week and send them home. So these are the three broad steps: measurement, selection, and sizing. So again, this is the step which shows the measurement, like I said. So here you see a daughter sac. Now, there's no need for the WEB device to go in the daughter sac. And again, if this aneurysm is going to taper like this, you don't need the WEB device to go there. You just need to measure up to this where you think the WEB device is going to end up. And I do these measurements on the two-dimensional studies. So this is from my friend, Dr. Delgado. You can see that the way he's measuring it, he measures the height to the shoulders of the aneurysm. He does not go to the very apex. And you can see that he has two different measurements here. So what we have to remember here is it's a braided device. If you put a smaller device in a larger aneurysm, it's going to foreshorten, and it won't have good wall opposition. If you put a larger device in a small aneurysm, it's going to stretch, and you may have it come out of the neck. So you kind of have to balance between these two factors, and it takes some experience to get the sizing exactly right. So selection of the device. So, here it says if WEB SLS device is selected, the aneurysm height, is shorter than the suggested device. If that happens, then you use the SL device, because SLS has, less sizes available. My general approach, so, here's the smallest height. That is the height you have to worry about, and this is the average width. My approach is always to undersize on the height and oversize on the width, and that is the traditional approach. You usually go up 1 millimeter on the width, so it's at 6.2. you end up with a 7. And then you undersize on the height, because since you're oversizing the width, it's going to stretch and have the height. Now, if your measurements are just right, let's say that it's 5 millimeters till here for your height. It's okay to even go to like 3. I'd rather undersize on the height and end up with a little bit more neck than oversize on the height and have the device protruding into the parent vessel. The other thing to really thoughtfully consider is the width. Again, you have to oversize it. Otherwise, you can see that it's very much susceptible to compression. So it's going to compact, just like coils. Right? And this is the usual system. The VI microcatheter, the intermediate catheter. I don't use any intermediate catheter other than Sophia for everything, stroke, pipeline, whatever it is. I haven't actually used this Sophia FX. I mean, the people who use Navion might like it. I'm not sure I need anything different. And then when we go to the microcatheters, 21, 27, 33. So there are a few tips for these things. With the 21 catheter, if you're having real difficulty in tracking it, either you can use a balloon or you can use 2 O1O wires and track it over that. With the 27 catheter, again the same thing. Either you can use a balloon distal, I'll show you how, or you use an O1O wire and an O14 wire. The 33, it's a shorter catheter. You actually track it over a 017 catheter. You can use Headway 17, XL 17, whatever you like, you can use that. And obviously the 21 goes through the 5, the others go through the 6. Now, if you feel like you need balloon in addition, the balloons are not generally going to fit in next to the VIA catheters, so then you have to have a larger sheath. So you get 8 French axis, or you do bilateral groin punctures, or if you're going radial, you can do 1 radial, 1 groin, something like that. Device preparation. So there's a little junction here at the back that's really notorious for kinking, so be really careful taking it out. And then you mate it just like you would for the microvention coils to make sure it turns green. And then you dunk it in water and make sure that there are no bubbles there. We usually pull back a little bit more before advancing it, and then we pull it back in. So the microcatheter positioning. Now, so in this slide, it says that it should be at the neck. It doesn't always need to be that way. If it's a really tortuous anatomy and there's a big angle, you want to get it as close as possible to the dome. But there is a catch here. The distal marker of the microcatheter is 1 millimeters proximal to the microcatheter tip. So do not advance it until your distal marker is at the aneurysm tip. And these are the steps in device deployment. My steps are very simple. I advance the device to the tip of the microcatheter. I unsheath until I get this shape. When it first comes out of the microcatheter, it is like a spear. If you have it at the vessel, at the aneurysm wall, it will go right through the aneurysm. So never advance it directly. If you're not at the neck of the aneurysm, if you're close to a wall of the aneurysm, doesn't matter if it's the dome, it's the side wall, do not advance it. Unsheath it. Once you get this shape, it's extremely soft. It's softer than any coil I know. And then you can advance it. So after that, you push. So unsheath, push. So here we are tip to tip. Here we've unsheathed, and you can see that it's formed this bulb-like shape, and then you push it. And eventually, it should assume its shape. Now, if it looks too good, like if it looks like the web you saw outside the patient, that means there's not good wall opposition. You should see some deforming because the wall is catching onto it. If it looks just like this, no good. So here's how it goes. So this synchro microwire via 21 in this MCA bifurcation aneurysm. Next, we're advancing the web device. So some of these slides are from my friend, Dr. Delgado. Sorry. So here, as we advance up, I'm going to tell you a couple of things. One, he has a lot of experience, so he's going straight in. But typically, you stop at this time, do a roadmap again to see how the anatomy has changed. So now he's tip to tip. So here's another ACOM. Similarly, it's advancing the device. You can see it's not at the dome, not at the neck, it's somewhere in between. But here you see this previous roadmap shows it beautifully. This was the contour of the microcatheter. Now look what the contour of the microcatheter is like. So it can really straighten out your system. So if you have your microcatheter near the aneurysm dome, it can go right through the dome as you straighten it out. The other thing that can happen is if you have it too close to the neck, it can come out. So you really need to go very slow around the bends, and you need to take your time doing multiple roadmaps. So once you're there, and you've deployed, let me see if, then you have to detach it. So for the detachment, you have to pull back the microcatheter well beyond the proximal marker. You have to unload the tension. You can see that there's a straight line here. And then you push on the detacher, and you have to keep pushing it. It's not like the coil. If you just hear a beep and you let it go, it's not going to detach. The other thing is it's attached in a much more robust fashion to the tip of the pusher. Sorry, Gabe, I'm running a little late.
Oh, good.
It may not fully detach. Then you have to advance the microcatheter gently to detach it. So here are the image stops we talked about. We'll go through that quickly. So here's an MC aneurysm. And here you can see that the aneurysm is coming at an angle. So in these cases, what I do is I inflate a balloon distal, and that helps my via catheter go in. This was our 6-month follow-up. This is a ruptured ACOM. So this is the kind of case that WEB is really beautiful for. There's one bleb here, one at the neck. We all know that having a coil go through a bleb at the neck is horrific. Getting control of that is really difficult. So this is a great WEB case. And because of the tortuosity, we went radial. This is almost a 10 millimeter height. The width is 4 millimeters. So I used a WEB 7 SLS. Here you can see that. Its height is 5.6. Since I put the 7 in a 4, the height went up. Just adequate. There we go. And that's our follow-up run. It was gone immediately. You will not always see that kind of stasis. It kind of depends on whether your patient is on antiplatelets or not. And this illustrates how you can deform the WEB. Now, if you really keep pushing it, these side lobes will come into the parent vessel. It'll block so you might think you've pancaked it and you're safe, but these lobes will be here. So we're going to keep going. Here's, so I mostly do a dyna-CT for follow-up. You can see that the parent vessels are preserved. So here are some tips and tricks. So this is ICA terminus aneurysm asymmetrically located at the A1 segment. So here, once again, I have this balloon. You can see the extreme angle at which it's coming off the ICA. It's a 90-degree angle. So I use the balloon for both tracking and also for supporting the device during deployment. So here you can see the beautiful illustration. Here's our microcatheter. It's at a 90-degree angle. And then we do the dyna-CT. This time around, you can see that's the WEB, and there's the bifurcation, clear. And here's our 3D of the dyna-CT. All right. So we can always use stents as an adjunct device too. So this is a patient who had a subarachnoid hemorrhage, wide neck, basilar, top of basilar aneurysm. Initially, I balloon coiled it. Then in 6 months, she had this recurrence. The height was not conforming to any particular WEB size. I didn't want to put coils again because the same thing might happen, considering how quickly it came back. So we advanced an Elvis headway 21, and we bounced it off the aneurysm to the microcatheter was bounced off the WEB device into the PCA on the right, and then afterwards we detached it, and you can see that was a post run, and this is how it looks when you use a stent and WEB. And then this is the reason why sizing is very important. You have to have good aneurysm occlusion. Device can rotate or compact. Here's a big aneurysm in a 81-year-old with cognitive problems. We didn't treat her initially, but she had subarachnoid hemorrhage. She wanted conservative management initially. So here I put in the largest WEB, the SL11. I'm just hurrying through these videos because I don't want to take up Dr. Toth's time. So look at the axis of this web device. Okay, I knew this is undersized. So after detachment, look at what happened. The web rotated, but we were prepared for it. So we actually put in a couple of coils around it. The other thing that can happen for you is device compaction. This person has like a mini solar system of coils in his head, and there's a recurrence of this MCA. So we put in a web device here. Look at the shape of the web device. Now we knew he's great at growing these aneurysms. This is the initial configuration. On repeat exam in 6 months, you can see the compaction. So sizing is very, very important. But you can use it with coils. So here there's a little residual neck that was webbed by my colleague. So main learning points are always ensure wall position, undersize on the height. I do not believe in being dogmatic about not using things. If your patient needs it, you got to use it. That's my thinking. And you always have to be prepared with the correct sheath, the right microcatheter, everything. And just because you have it doesn't mean you need to treat everything with that. Thank you. And then this is an unofficial part that I threw in just to give poor Todd a heart attack. So there's a right pica aneurysm in that same patient. So this, I just wanted to play this because it's very illustrative of how I use the balloon. It will only take like 1 minute. So here we go. We are tracking the VIA21. This is a tiny aneurysm. Could we have clipped this? Yes, but this patient has cognitive difficulties. She already had a subarachnoid. So it's going to get hung up here at the neck. And every time I try to advance the microcatheter, it will push out. So I took the septer from the other vertebral artery backwards into the pica. There's a particular reason I did it, not to look cool, but we're going to see it in a second here. We're going to inflate the balloon. As you can see, I do things really slowly. So balloon is inflated. Now I'm going to try to re-advance. This was after multiple attempts, okay? I didn't go crazy the first time with the balloon and stuff. So now I'm going to advance the VIA. There, it's in place. That's what you use it for. And then here's our web. Here's the septer. I wasn't sure that it's not protruding into the little pica, so I ended up putting an Atlas stent through it. And here's our Dyna CT of it. There we go. So everything is protected. So thank you very much for listening. I'm sorry it's a hurried presentation, but there's a lot to discuss in 20 minutes. Thank you. And we'll take questions at the end. Thank you.